สวัสดีครับ Hello, my name is Thisayakorn. I'm the consultant psychiatrist at Chulalongkorn Hospital, Bangkok, Thailand. And today is my pleasure to be participated in the lecture about depression and HIV. So there are well studied and well documented evidence regarding the interaction between HIV and depression, and the literature conclude that there are the bidirectional relationship between HIV and depression. For example, the direct infection of HIV virus into the CNS, the disturbance of the inflammatory process, immunological impairment, the effect of some of the antiretroviral drugs can cause the depression. Moreover, the impact of the psycho and social process of HIV, such as stigma, can also be the contributory factors for developing the depression. On the contrary, the depression itself also has the impact on the HIV. Depression also carries the inflammatory process that worsen the both mood part of the brain and the part of the behavior and symptoms of HIV. Biopsychosocial part of depression, several factors worsening the cause, the outcome of the HIV. And further from the study, we also find that the relationship between HIV and depression eventually lead to the worsening poorer outcomes from both sides. For example, poorer control of the CD4 viral load, more morbidity, mortality of this population, worsening compliance, worsening social support, worsening quality of life. And here is the most recent meta-analysis that study about the global prevalence of depression in people living with HIV. The sample size is quite big, 50,000 people, and they found that the people who suffered from clinical depression was around 14,000 people, calculated into the prevalent rates of depression in people living with HIV is about 31%. Higher prevalence was noted in the people who live in the underdeveloped country or developed rather than the developed countries. And interestingly, the Southeast Asia, the region of the world where I'm living in right now, has the highest prevalent rates of depression in HIV at 40%. The data from last year, 2019, show that even though the prevalence of the HIV in Thailand is gradually slowing down, but the number of the HIV cases last year is still as high as 470,000 people. With the total population in Thailand, about like 66 million people, it is around like 0.71% of the people who has HIV living in Thailand. And if we use the lowest prevalence number of depression in HIV from the previous slide, we can roughly calculating that the Thai people who live with HIV who also suffer from depression is about like 130,000 people. I further calculate the data from Medical Council of Thailand show that last year there are around like 1,000 psychiatrists in the country. This means that if we think ratio between one psychiatrist and the HIV people who suffered from depression is about 1 to 115 patients. Not that bad, huh? But in reality, the ratio must be much, much higher because not all the psychiatrists can take care of this special population. And the psychiatrists also need to take care of like several type of patients like major psychiatric disorder or the patient who suffer from mental health from other medical areas. So there are the shortage of the psychiatrists. There are the big number of the people living with HIV who suffer from depression. And that comes to the talk that I will present today, 1 to 3 to 10 depression and HIV, that I try to think about what I have learned, what I have worked with the whole team to improve the steps of care in the people living with HIV who suffer with depression. The first step is to buy in the psychiatrist. And I literally said that you just need to buy in the psychiatrist, buy them the coffee, buy them the snacks, invite them to join the social activities, buy them the t-shirt, like the shirt that I wear today is also from the infectious disease team. Invite them to the academic activity like lectures, conference, interdepartment academic activities, and perhaps invite them to join the research that would make the participation, the relationship between both teams to be stronger and get the commitment from the psychiatrist. Once you have psychiatrists, it is worthwhile to find a case manager who is maybe the key of the whole team, not the psychiatrist, not the infectious doctor, but the case manager, which can be the registered nurse, social worker, medical assistant, volunteer, expert patient can also take the role of the case manager. They work along the patient, they work along and get the supervision from the psychiatrist. Their role is to combine, to communicate between the whole sections of the system: implementation, facilitation, coordination, assistance. The intervention they provide quite a lot, but it is like well studied and can be implemented not too difficult to our patients. Screening, diagnosis, monitoring, education, provide the counseling, provide the care, improve the adherence, and also the emergency management. Once you have psychiatrists, you get the case manager. Before you start to do something with this population, think about the emergency plan, because it must be like super confusing and difficult if you screen positive for the severe depressive patients with the active high suicidal risk and you have no plan in your hand. Think about the emergency plan ahead, safety in everything, plan, protocol, contact, assessment, intervention, or the plan to admit the patient into the psychiatric hospital. Then, when we have the plan ahead in hand, we start to screen the patients. There are several screening tools that can screen for the depression and are well studied in the HIV population. We recommend the PHQ-9, which is like which was studied in several studies, several HIV populations, and it is the easy to use 3 to 5 minutes pen and paper screening tool, self-rate. It can use as the screening tool to diagnosis of the depression. It can use as the monitoring tool to see the improvement or worsening of the depressive symptoms. 2019, the European AIDS Clinical Society guideline recommend that we screen PHQ-2, the first two items of the PHQ-9, anhedonia, lack of interest, and the depressed mood in every HIV patients in every 1 or 2 years. If the patient screen PHQ-2 positive, they may further be screened by PHQ-9. And after we calculate the sum of PHQ-9 scoring, we connect it with the step care. Step care determine the severity of the depression and connect it with the level of appropriate psychiatric care. For example, 0 to 9, no or mild depression. We just need to wait and see and repeat the PHQ-9 annually. Moderate depression, this is in the range of clinical depression, 10 to 14 score. We can provide the counseling and all pharmacotherapy. Moderately severe depression, 15 to 19, the whole team need to become more active in terms of providing the psychiatric medications or psychotherapy. The severe depression above 20 scoring, immediate attention need to be given. Talk about the starting the antidepressant, talk about sending the patient to see the psychotherapist or even the urgent psychiatric visit referral. Screening tool is not enough. You just also need to diagnose the major depressive disorder with the clinical interview. It can be done by primary doctor, infectious doctor, nurse, social worker, case manager. You may not be familiar with talking about mood, talking about emotion, but you start with the routine physical care of the HIV patient. Then you ask about the common physical symptoms that can occur in both HIV and depression, such as weight loss, slowing down of the movement, or the sense of fatigue, lack of energy. Then you go to the middle part of the diagnostic criteria, that is in between the emotional part and the physical part. Asks about how they sleep, asks about the lack of concentration, the worsening of the brain capacity, memory, attention. Then you move into the more emotional part that you may not be familiar, but once you go step by step, it is easier and the patient would likely open to discuss about, are you depressed over the past 2 weeks? Do you lose interest? Can you enjoy things around as usual? Do you feel worthless, helpless, hopeless, or guilt inside? Do you feel like some days in the past 2 weeks, you feel like life is not worth living? Um, do you have suicidal ideation? Do you have plan or intention to do it soon? So after you ask through this list of criteria, you are likely be able to diagnose the major depressive disorder. But yes, some of the HIV patients has the overlap symptoms of the depression. For example, weight loss or insomnia or fatigue. Sometimes we use the supplementative criteria, the substitutive criteria to give us a clue for depression diagnosis. Are the patient irritable, tearful in front of us, look depressed, withdraw from the society, just like have a lot of the negative thoughts, rumination inside all the time? This may give us a clue to be more confident with diagnosing the major depressive disorder. 6. Counseling and psychotherapy. Once we diagnose, the first step is not pharmacotherapy. The first step is to provide the communication, provide the interaction, counseling. It can be provided by you, the doctor, the social worker, the nurse, or the people who work in the HIV setting. Just use the basic counseling concepts, supportive psychotherapy. But if you have the team, like case manager, you may send them to learn more about the cognitive behavioral model, interpersonal model, or learn how to run the group therapy, because all of this model are well studied in the HIV population and prove that it improved the depressive symptoms. But if you have no time, just use the common basic counseling interaction skill that we all the medical personnel all have, like empathic listening, support and hope providing, education, motivation for the good physical activities, etc. Counseling in the moderately severe or severe depression, you may need to prescribe the antidepressant. Not only psychiatrists, but all physicians can prescribe the antidepressants. There are like 10 medications which are studied in the HIV population, but I just picked these 3 medications because it is widely used and easy to use. in HIV people. First one is sertraline. One tablet 50 milligram. You start at 25, 1 week, go up to 50, continue at 50 for 6 to 8 weeks. If the symptoms persist or if the patient hasn't reached the remission, clear of symptoms yet, consider to go up one step to 100, 1 or 2 months to 150 or 200. No effect on antiretroviral drugs, but protease inhibitor may inhibit the metabolism of sertraline, therefore increase the level of sertraline. Nevirapine and efavirenz induce the metabolism of this medicine and lower the dose, the level of sertraline. Escitalopram is another safe medication that can be used in the people living with HIV. One tablet, 10 milligrams, start at 5, 1 week, go up to 10, wait for 6 to 8 weeks, then you can go up to 15 and 20, no drug interaction at all. Fluoxetine, very first SSRI, serotonin reuptake inhibitor that we use for up to 30 years. One tablet 20 mg, start at 10, go up to 20 in a week. Then you may go to the step of 40 or 60, but need to check for the drug interaction because fluoxetine can increase the ritonavir level and protease inhibitor can greatly increase the fluoxetine level to the point that there are some case series of fluoxetine plus protease inhibitor causing the serotonin syndrome. Nevirapine, similar to sertraline, can reduce the dose level of the fluoxetine. The common side effects are annoying but not life-threatening. Sertraline, fluoxetine, 10 to 30% can develop GI symptoms like nausea, vomiting, diarrhea, abdominal discomfort, neuro side effects like dizziness, headache, anxiety, and insomnia. Escitalopram is a bit less, like 20% that develop these side effects. You just need to tell the patients that it costs about 20-30%. It occurs over the first week. Try to be with it, tolerate it, and then within the next few days, most of the side effects subsides. No serious side effects at all. The rule that we always tell other clinicians that is not the psychiatrist is to start low, go slow, but go. Titrate dose up every 6 to 8 weeks to reach the clinical response, which means no symptoms at all. Side effects, I talk about it. Nighttime dosing with the antiretroviral drugs may enhance the compliance because it's more convenient for some clients. The first 2 or 3 months, you may also prescribe the low dose of benzodiazepine like lorazepam 0.5 to 1 mg at nighttime to help sleep, anxiety, and cover some side effects of these medications. When we start, we monitor, we have the goal in our mind, we have the limit duration of prescribing. People hit the bottom and start the antidepressant. 2 or 3 months, we like to see the response, which is the 50% improvement of the symptoms from PHQ-9. In 3 or 4 months, we like to see the remission, which is the clear depressive symptoms of PHQ less than 5. Once we reach the great response or remission, we just need to continue the medicine at the same dose for 6 to 12 months to prevent the relapse. And once the patient maintains on antidepressant and hasn't had any depressive symptoms for 6 to 12 months, you may consider to decrease and stop the antidepressant. We don't like the patients to have the antidepressant on board forever. In some cases, with severe depressive symptoms, despite adequate treatments, time, dose, intervention, you may need to consider for psychiatric referral. Complex psychiatric diagnosis or comorbidities like HIV/AIDS plus depression plus psychosis or bipolar depression, PTSD, substance use, neurocognitive disorder, or organic psychiatric disorders. For example, you You are thinking about some psychiatric presentations of the brain mass, cryptococcal meningitis, delirium, or effervescence-induced psychiatric symptoms. You may need the psychiatric referral. Patient is in great acute danger to self or others. Psychiatrists may help you to work on with these more difficult patients. Once you walk to those nice steps, your team, yourself will have more confidence, more experience to think about how we can improve the whole system to the next step. Starting from the different sector, different hospital, HIV, mental health sector, we try to integrate the whole care under the same roof, like one-stop clinic that has the infectious disease doctor sitting next to the mental health doctor, but it's time and resource consuming. We try to put everything in the same hospital and just consult to different departments, but it's still separated. So at one point, maybe the highest level of mental health care in the HIV setting that are evidence enough is the collaborative care model of caring the patient with HIV and depression. Again, the case manager is the key that facilitate and communicate with the whole team, but we implement and we monitor and we make it to be the systematic care model to improve the depression and HIV. You can read more about the collaborative care in several articles. And this is all I like to talk today. Depression is common, lead to the worsening outcome. And we try to implement the screening tool, monitoring tool, management plan to help our patients. And by working, learning together, slowly the whole team get more confidence, experience, ability to help with our patients more. Thank you.